Hello, this is a presentation of my dissertation research, which examined cultural influences related to healthy weight care in Burmese American children. Childhood obesity was the original problem which caught my interest. Childhood obesity rates have increased steadily since the 1980s, and it is estimated that currently in the U.S., 1 in 5 children are obese. However, it was the obvious disparities in childhood obesity which narrowed my focus. Rates of childhood obesity are disproportionately high in racial and ethnic minorities. These populations have been historically marginalized and are affected by persistent health disparities. Research examining influences into childhood obesity have found multiple influences, all the way from genetic predisposition, infant feeding, lack of sleep, and built environment, just to name a few. In a review of the literature, however, 3 gaps were identified, and culture was one of them. Cultural influences are rarely addressed in research, despite ethnic minorities having a disproportionate burden of childhood obesity. There is a lack of the child's perspective in the qualitative studies, even though this is a child health problem. And there are few studies examining smaller ethnic groups. So the study purpose was to discover cultural influences that contribute to or prevent childhood obesity from the perspectives of Burmese American children and adolescents of Karen ethnicity in the Southeast U.S. The goal of this study was to use this knowledge to promote culturally congruent healthy weight care in the Burmese American community. Healthy weight care is a promotion of a lifestyle rather than a diet to achieve healthy weight. Culturally congruent healthy weight care is a lifestyle that fits the cultural values of children and families while providing actions beneficial for healthy weight. The conceptual framework for this study was Leininger's culture care theory. The culture care theory is used to discover and explain the interdependence of care and culture in order to provide culturally congruent nursing care. The culture care theory views participants as the experts and teachers of the researcher. The study design was the ethno-nursing research method, which was developed by Leininger to be used with the culture care theory. The participants were Karen children between 8 and 16 years of age, their parents, and members of the English-speaking community who knew them. Children were key informants. In ethno-nursing, key informants are the most knowledgeable about the research question. There were 10 key informants interviewed, 5 males and 5 females, and they were divided equally between 2 age groups, which included school age and adolescent. There were 18 adults who were general informants. 5 of those adults were either the grandmother or the mother of children. The Karen are one of 135 ethnic enclosed enclosed in Burma. They live along the border, the very south part of Burma, along the border with Thailand. They are community-oriented, with a strong respect for elders, living traditionally by farming and hunting. The Karen do not consider themselves Burmese, having a separate language, culture, government, and army. They have been in a continuous civil war for 70+ years with various Burman governments. Human rights abuses of ethnic minorities in Burma have produced multiple waves of refugees escaping from Burma. Refugees from Burma have spent decades in refugee camps. Imagine the environmental shock upon resettlement in new communities. Our families found themselves in an urban sprawl of busy 4-lane roads with no sidewalks, no green space, no parks, and sporadic public transportation. Cross-language research was very important to this study. The parents of the children spoke only Karen, and I spoke only English. The research required cross-language methods using an interpreter and translator from the beginning. The difference between an interpreter and a translator is that an interpreter conveys words orally from one language to another, whereas the translator converts text. The interpreter for this study was the interpreter for the public school system. She functioned as a gatekeeper and cultural broker for the Karen community. She was essential for introducing me to the parents and establishing trust with the parents. Data collection began after a 9-month immersion period, which allowed for the establishment of trust with the children and with the gatekeepers of the children. I volunteered with a faith-based community which served the Karen community. This period provided observation notes, which added meaning to context of what was heard during the interviews. Interviews were face-to-face in either the home or the faith-based organization until the pandemic. With the pandemic, interviewing switched to Zoom. Zoom worked well in the English-speaking community, but proved to be a barrier in the Karen community. Gratefully, over half of the key informants were interviewed prior to the pandemic. The goal of this study was to discover influences on healthy weight care in Karen children. Analysis and synthesis of data revealed 4 themes. The first theme reflected healthy weight care and the descriptions of a healthy child. Almost universally, a healthy child was described as being active, and children also stated that being active was a way to be healthy. There were very few physical descriptions given, but some children did state that a healthy child was not too skinny and not too fat. Behavior was a pattern that was noted also. Mothers described a healthy child as being respectful and dutiful, while children described it as being good and having respect for others. Although all adults considered Karen children healthy, a surprising finding was that some children didn't consider themselves healthy. When I asked why, one adolescent girl replied, "For us, there is no eating time. We eat whenever we want." The part of the interviews about food was the most fun. Both children and adults loved describing food. It soon became evident that food and food preparation was how Karen people showed care and how children felt cared for. And as one mother said, "For me, I try my best how my children have to be healthy, and I give them all my love, and then whatever they want to eat, good or bad, I choose for them and let them have the food." Traditional food was predominant in the children's diets. This was the Karen food. Karen meals consisted largely of vegetables cooked with rice and fish paste or other spices added. Liquids accompanying the meals were either soups or water, sometimes milk. Children listed their favorite foods to include American and Karen dishes. However, when they ate American food, they often covered it in sriracha sauce. Because of most parents working long hours, all families reported unstructured meals. This meant that a pot of food would sit on the stove ready for the children to serve themselves when they got home from school. It reminded me of the homes I had visited in Appalachia and Mexico, where there was always a pot of beans on the back of the stove. The universal pattern was that school food was awful. One girl described it as jail food, and another boy said that the meat looks raw and the vegetables look dead. Most alarming was one adolescent girl who stated that she didn't eat at school all day, even though she was eligible for both breakfast and lunch at school. The third theme dealt with the difficulties of getting physical exercise. Universally, the girls were sedentary. They reported that after school they just studied or watched a movie, and one girl said, "I stay in my room all the time, draw, watch movies." Boys reported playing ball outside after school. There were some serious barriers to getting physical exercise. Most families interviewed didn't have a way to transport children home from after-school activities, which meant these children couldn't participate in sports. At-home barriers to physical activity were lack of places to play. Ironically, families who had moved from the crowded apartments into single-family homes had less play space. The apartment complexes provided playgrounds and football pitches. In addition, a teacher described their PE department going out to the apartments and giving the kids bikes and balls for the apartment complex. It was interesting to note the contrast in what the girls were telling me they did after school and what had been recorded in my observation notes at the faith-based community. The notes included descriptions of the girls running around, chasing each other, or playing ball in a group with the boys. Theme 4 and the last theme had to do with caring and support, which were part of the 3 communities that these caring children had contact with: their family, their school, and their faith-based community. I want to emphasize that the care and support was mutual among all groups. The caring did not just receive help, they provided it to their new community also. Mutual care and support is an important caring cultural value. School-aged children describe providing care and support to their families through their chores, which is very developmentally appropriate for this age group. The girls noted that they were restricted from doing what the boys could do because their families cared. As one adolescent girl explained, that her family wants to protect us from the world. They don't want us doing dirt or nothing. They love us. Caring children had a mature recognition of the care received from their parents' long work days to pay bills and to send money back to family members in refugee camps. Faith-based community members and school teachers described with cultural brokering when caring children needed medical care. There were multiple stories of community members and teachers having to advocate for caring families in the healthcare system that wouldn't take the time to listen to these families. In the culture care theory, practice implications are expressions of care for and with the client rather than interventions applied to the client. The child and family are partners in the healthcare team. As nurses wanting to provide culturally congruent, healthy weight care, we look at what people are doing right first and encourage the preservation of those practices. Using what was learned from this study, a nurse would want to preserve and encourage caring families cooking traditional meals and drinking water with meals. Nurses would validate and encourage the view of health as being active and could encourage the continued physical activity of the boys. In addition, the maintenance of mutual support within the communities is an important practice implication. Negotiating or repatterning is included in culturally congruent care when there are some practices that are not fully beneficial for health, or in this study for healthy weight. Based on findings from this study, the nurse would want to negotiate for culturally accepted ways for girls to increase physical activity. As noted in the observation period, when given a chance, caring girls would be as active as the boys. The key is providing a place for activity which caring parents trust to watch and protect the girls, such as the faith-based organization in this study. Repatterning is needed in the environmental context of these children, and it needs to be addressed through policy. In addition, nurses need to advocate for repatterning of healthcare visits to allow time for effective communication. The policy change mostly is needed at the local level. One is to address transportation issues for after-school activities. School nurses can advocate for local school districts to extend school bus hours so that more students are able to participate in after-school sports and activities. Another local policy to address is school cafeteria food. School meals are a significant source of nutrition for 30.4 million children in this country. Children should be part of the local school planning of meals. In a study in which children were involved in the design and implementation of a school lunch project, they were doing taste testing with herbs and spices added to the vegetables. This project found an 18.2% increase in vegetable intake. At the state level, there needs to be an increase in physical activity requirements in schools. In Tennessee, currently, elementary schools are only required to give students 15 minutes a day of physical activity, and middle and high school only 90 minutes a week. This falls seriously short of the 60 minutes a day of physical activity recommended for these age groups. Children spend the majority of their day at school. Increasing physical activity during the school day would benefit all children and help to reduce the continued trajectory of obesity in the school age and adolescent age groups. Findings from this study are limited to this caring community in this Southeast U.S. urban area. Although limited in transferability, findings could be used for research into healthy weight influences with other ethnic minority children. The use of an interpreter during parent interviews was an intrinsic but necessary limitation. Use of an interpreter was also a strength because it provided voice for a non-English speaking group rarely heard in childhood obesity studies. So what are some of the take-home messages from this study? Number one, we can gain valuable health knowledge from other cultures, especially less studied cultures. And second, it is important to remember that at-home cooked meals, especially if they're traditional to the culture, can contribute to healthy weight care. Access to physical activity is important for all children and is a priority policy work. And nurses need to advocate for and provide voice to all children and groups experiencing health disparities. I would like to acknowledge the financial support of the Crawley Dean's Chair Scholarship and the grant from the Society of Pediatric Nurses. Thank you for your attention.